They send you. They send them to each other. Like, damn girl. I don't work it out.
I'm not joking. I'm not joking. No. Yeah, not tell Paul.
Hi again.
Is there any caption?
What is this beautiful woman's name? This lovely lady.
Oh, that's not her.
This lovely lady.
I don't know, Paul.
That's the right answer.
Okay, good morning.
Morning.
Again. The class average without any adjustments was 78%. Okay.
Whoa, that's pretty good.
That's pretty good.
That's the best ever.
Average, without adjustments. And I told you that there'd be at least one bonus question because, you know, I put 49 questions in instead of 48. So.
Do you know what the bonus question is off the top of your head?
It makes absolutely no difference to the grades.
You know the answer.
Well, it doesn't matter. Well,
He's just giving you an extra point.
Yeah.
Right, but I just didn't know if you had said. Never mind.
I'll work it out when I look at the questions.
Don't overthink it.
When I look at the questions, I'll make a decision. Okay. But it doesn't matter whether you get the bonus question right or wrong. You get the same advantage on your grade.
Oh.
Okay.
Yeah. It's a 3 point.
Basically.
Yeah, I thought it was like a specific question. Yeah.
Well, even if it's a specific question, it doesn't matter whether you get it right or wrong. It makes the same change to your grade.
Right.
Yep. So.
Of course.
Okay. Couple of things. We need to finish the chronic kidney disease first. Calm down, guys. Exam's over. Okay. Chronic kidney disease. Finish that off. Then we'll talk about some other glomerular diseases. We talked. I mean, chronic kidney disease is a major one. You know, diabetic nephropathy is a major glomerular problem, but there are some other conditions as well that we'll talk about. I will be out of town on December 14th. That is essentially the last class before the final exam. We've got a class on the Monday, but I usually have that as a review session. I'm not sure what's going to happen to that class yet. I'm going to see if Dr. Lindblad will switch with the 371 on the Thursday morning. If not, then there may be no class that day. What I might do is to record it and post the slides, but we'll see how it goes. Okay.
I would love to sleep in.
No, we will have a Patho quiz on the Tuesday before finals week. Okay. That's the last quiz. On Tuesday, whatever it is, the 11th? Yeah, okay. Okay, chronic kidney disease. This is sort of where we got to. It's a problem with the glomerulus initially. There's some factor that causes glomerular damage and leads to, you know, potentially a loss of glomerular filtration to compensate to make sure that the kidney doesn't lose this, doesn't have a decreasing amount of filtration. It increases filtration in the nephrons that are still working properly. And it does this by constricting, the efferent with angiotensin II. So it's called an adaptive hyperfiltration. So you're getting hyperfiltration of the remaining nephrons that are working okay. The problem with this is it works fine for a while, but then over time it causes damage to the glomerulus and you start filtering proteins. And the proteins themselves cause damage, and you start getting damage and an inflammatory cascade within the tubules as well. So you get tubule epithelium, tubular epithelial cells taking up the proteins, initiating an inflammatory cascade. This inflammatory cascade includes the usual cells, but macrophages are major players here, so are the T cells. And there's release of cytokines, inflammatory cytokines, upregulation of NF-kappa B, nuclear factor kappa B, transcription factor, upregulates the production of a whole host of inflammatory cytokines. And the three major ones that we'll keep talking about in lots of these conditions is TNF-alpha, IL-1, and IL-6. So upregulation of NF-kappa B transcription factor leads to the upregulation of these inflammatory cytokines. There's also production of reactive oxygen species, which itself is a major inflammatory mediator. There's also release of various growth factors. And the major one is TGF-beta. I think I told you the name incorrectly yesterday. For some reason, I think I said tumor growth factor. It's not. It's transforming growth factor beta. So this is a major growth factor in the generation of tissue fibrosis in several different conditions. And this, upregulates fibroblasts, causes the production of fibroblasts from the epithelial cells, and you get fibrosis and scar in other tissue. In diabetes, it's one type of chronic kidney disease. The initiating factor is the hyperglycemia, and the high levels of glucose intracellularly and extracellularly causes problems with protein structure. You get these advanced glycation end products because of glycation of the proteins, not glycosylation, and upregulation of phosphokinase C, which again, it leads to inflammatory mediated release reactive oxygen species. So that's where we got to. The kidney, in chronic kidney disease, major effects for the whole of the body, and it affects just about every system in the body. You get direct effects and effects because of the problems with sodium and water retention. So the renal effects, you get sodium and water retention, so you get expansion of the extracellular fluid, expansion of the blood volume, leading to increased blood pressure. So hypertension is one of the prime factors that you see in chronic kidney disease. The hypertension itself leads to further damage to the nephrons. There is, because of sodium retention, not because of sodium, you also get retention of potassium, and you get a hyperkalemia, and potassium has major effects on smooth muscle, including the heart muscle, and so it leads to problems with the electrical conduction there, and you get arrhythmias. There's just decreased renal function, so you start excreting less of the urea, the other toxins, so you get built up in the blood. You get a uremia and a high level of creatinine. There's other changes that you see because of problems with hormones and other factors that are produced in the kidney. And when you start losing renal function, you start getting decreased production of these other factors. So you see anemia, and that's largely due to the decreased production of erythropoietin, and so the production of red blood cells. And the erythropoietin comes from the kidney. Excuse me. Got an itchy nose.
You're gonna kiss a fool.
What's that?
You're gonna kiss a fool.
Okay. I think I'll stay with the itchy nose. Okay. So anemia. There's also dyslipidemia. Other hormones. One that we will talk about, vitamin D. There's the final activation step for producing the active form of vitamin D occurs in the kidney, and so in chronic kidney disease, you get decreased production of vitamin D, decreased absorption of calcium from the GI tract, and it leads to bone loss, osteoporosis, things like that. This is a major disease now. It's recognized as a separate, not a separate condition, but chronic kidney disease with something called MBD, major bone disorder. So this, you'll see this CKD, MBD around, and it's because of this decrease in the production of vitamin D, which has some other effects that we will talk about in a minute. Okay. Metabolic acidosis is very common because you are losing the ability to excrete hydrogen ions in the collecting duct cells. So the body needs to get rid of hydrogen ions, and it can't do it because you're again, just a general loss of renal function, loss of the cells, the intercalated A cells in the collecting duct that produce and secrete the hydrogen ions. So metabolic acidosis is common in chronic kidney disease. As the renal function gets worse, then organic anions accumulate. Hyperkalemia, the high potassium, also suppresses bicarbonate absorption. So you're not excreting hydrogen ions, you are absorbing less bicarbonate, so metabolic acidosis is a major consequence of this. And then also chloride, remember chloride and bicarbonate are sort of exchanging in the collecting duct. Well, you're not absorbing the bicarbonate, so you excrete less chloride, you get a hyperchloremia. And there is a type of acidosis that is real common in chronic kidney disease. It's called hyperkalemic, high sodium, high potassium, hyperchloremic, high chloride. So it's listed as type 4, renal tubular acidosis. Real common in chronic kidney disease, especially in diabetic nephropathy. So high levels of potassium, high levels of chloride, and a metabolic acidosis at the same time. The major system that causes the real problems in chronic kidney disease is cardiovascular. And we'll get to that in a minute. But also, there are major bone problems as well. As I say, this is now being recognized as sort of an entity in itself, chronic kidney disease with major bone disorder. And it results from problems with calcium and phosphate. So a couple of things that happen. One is that the decreased glomerular filtration rate causes the decreased excretion of phosphate. So you get a hyperphosphatemia, you get high levels of phosphate in the blood. Decreased renal function also decreases the activation of vitamin D. I've mentioned that. The active form of vitamin D is calcitriol, and the final activation step is a hydroxylation that takes place in the kidney. So if you have blood samples drawn and you measure vitamin D levels, what you're measuring is not the active form typically, because the active form is in real small amounts. But there's two activation steps for vitamin D. One occurs in the liver to form the 25-hydroxy vitamin D. That is what is typically found in the serum in large amounts. That is what's measured in a blood analysis. And then the second hydroxylation step is the 1-hydroxylation that occurs in the kidney. If you don't have vitamin D, active vitamin D levels that are sufficient, then you do not absorb calcium from the GI tract. Not very well anyway. Vitamin D is required for optimal calcium reabsorption from the GI tract. So without vitamin D deficiency, you don't absorb the calcium and you get a hypocalcemia. Both of these factors, the high levels of potassium, of phosphate, and the low levels of calcium, upregulate, they are stimulating factors for parathyroid hormone. Parathyroid hormone comes from the parathyroid gland, sort of in the middle, real small gland around the thyroid gland. And PTH's goal in life is to regulate extracellular levels of calcium. And so if there's low calcium, you get stimulation of parathyroid hormone, and it causes increased reabsorption of calcium. It tries to upregulate vitamin D, and it also causes bone remodeling. It turns over bone, and in doing so, it releases calcium. So if you have a lot of parathyroid hormone, you get a lot of calcium release because you're chewing up the bone, and it can cause problems with the bone down the road because, I say, the goal of PTH is just to maintain the levels of calcium. So both of these factors, the high phosphate, the low calcium, stimulate parathyroid hormone secretion, and this is called a secondary hyperparathyroidism. So high levels of parathyroid hormone caused by other factors. So high levels of PTH, bone loss, bone pain, and eventually leads to osteoporosis and fractures. There's also, the PTH is trying to increase calcium levels, and it increases calcium levels, and it leads to vascular calcification. And there's a condition called calciphylaxis, where you get calcification of the vessels in the skin, and you can very easily, these vessels are very delicate, and they can block off very easily, and they can lead to skin necrosis. And this is a picture of someone who's got calciphylaxis, skin necrosis, from dialysis tubing. And so the dialysis tubing was lying against the skin, causes, pressure on the skin. And because of these vessels because they're calcified, you get this condition called calciphylaxis. So changes in calcium and phosphate can have major consequences in chronic kidney disease, bone loss and vascular calcification. Okay. Right. Okay. Cardiovascular effects. Cardiovascular conditions in chronic kidney disease are the major cause of morbidity and mortality. Ischemic vascular disease, so you see increased risk of stroke, increased risk of myocardial infarction, and this is caused by the inflammatory response, which becomes systemic, and also because of the hyperlipidemia, which increases the potential for atherosclerosis, so laying down of fat tissue on the vascular endothelium. There's also heart failure, the hypertension, and you'll cover this next semester with Dr. Lindblad. When you get hypertension, it causes an increased load on the heart. It's having to pump against a higher pressure, and one of the compensating mechanisms for this is hypertrophy of the cardiac muscle, and so you start getting cardiac hypertrophy because you've got a higher blood pressure. Starts off with the left ventricle, but it involves other part of the heart as well. And so the hypertension is the initiating factor for this, but then down the road, the cardiac hypertrophy can lead to congestive heart failure. And there's also, the major cause of the hypertension is this volume expansion because of the sodium retention, and there's upregulation of the renin-angiotensin system. So you release angiotensin, major vasoconstrictor, and it's a major player in producing hypertension. And there's also, because of the increased levels of urea, you get an inflammatory response in the pericardium. It's called uremic pericarditis, and this can lead to other cardiac complications. So cardiac disease, cardiovascular disease, major causes of morbidity and mortality in chronic kidney disease. There are some other effects. There are changes in other hormones, so you get problems with the thyroid gland. You get changes in output of the sex hormones, so there is sexual dysfunction in people with CKD. Neuromuscular, especially in diabetics, you get the diabetic neuropathy as well as nephropathy. And then so they get nerve problems as well. But also just in people with chronic kidney disease, there's other neuromuscular problems such as fatigue and myopathy. So you start getting muscle pain, but you can get muscle breakdown as well. GI and nutritional, malnutrition, anorexia, GI bleeding. There's hyperlipidemia. There's also abnormal metabolism of fats, carbohydrates, and proteins. So there are metabolic effects for all of these pathways. And there's an increased risk of infections. And so when people have or are diagnosed with chronic kidney disease, it's really important that they get the appropriate vaccinations against pneumonia and things like that, because they have this increased risk of infection. Okay. So, which is not a hyper feature of chronic kidney disease? Hypertension, hyperkalemia, hyperphosphatemia, hypercalcemia, and hyperparathyroidism. I assume I need to stop it. So. Ready? No? No? Oh. I guess I should give you all little paddles or something like that, and you hold it up, so tell me to wait. Ready? No?
Dr. Phil, I thought you were gonna give that the lady got divorced 3 times as a bonus on the exam.
What on the exam?
You know, we always give like some person some.
Oh, well, I typically don't put pictures on exams, but you weren't in the room because you were downstairs. But there is at least one bonus question, because I couldn't decide between 2 questions, so I put them both in, so there were 49 rather than 48. So yeah. Okay, you ready now, Cordell? Okay. Okay. Show correct, show results. Oh.
Let's not put that one on the next test.
Okay. Hypertension is major. Hyperkalemia, high potassium levels, okay? Remember the hyperkalemic, hyperchloremic acidosis. High phosphatemia, high levels of phosphate because you're excreting less. Hypocalcemia, because you're not reabsorbing the calcium because of the low levels of vitamin D. Okay. And then the hyperphosphatemia and hypocalcemia lead to hyperparathyroidism. So hypercalcemia was correct. Boy, that would have to be a bonus question, I think, on an exam. Okay. This is information only. But it's real important. So it won't be on the exam, but as I say, it's really important. How do you treat and slow the progression of chronic kidney disease? Hypertension, controlling the hypertension is number one. There's hypertension in the glomeruli that initiates the whole of the cascade. And hypertension is one of the major factors causing the morbidity and mortality that you see with the disease. So you want to control the intraglomerular hypertension and also the general systemic hypertension. So first-line therapies, ACEs, ARBs, diuretics, typically. Sometimes calcium channel blockers. There are some ethnic differences in responses to these drugs. So calcium channel blockers are typically first-line therapy in people of African descent, okay, because they respond less well to ACEs and ARBs compared with Caucasians. Diabetic nephropathy, glycemic control. controlling the serum levels of glucose is, again, crucial because this is a major player in causing the initial damage in the glomeruli. Protein restriction. You're getting one of the major, initiators of the inflammation, once you've got the glomerular damage, are the proteins filtering through the glomerulus into the tubular capillaries. So decrease in protein intake slows down the damage that the protein causes. Salt and water restriction. So you're getting sodium and water retention, which increases the extracellular fluid volume. So restricting salt and water intake. Reduce hyperkalemia by a low potassium diet and certain diuretics. The potassium wasting diuretics are used in this condition, not just as diuretics, but to get rid of the potassium as well. So furosemide, loop diuretics and thiazide diuretics are the ones that are potassium wasting. Okay. The ones that work in the collecting ducts, the amiloride and the aldosterone antagonist spironolactone, these are potassium sparing. They would not be used in chronic kidney disease. Phosphate restriction, phosphate binders to try and reduce the hyperphosphatemia and try and decrease the output of the parathyroid hormone. And then when all else fails, people go on to dialysis and or kidney transplant. Okay. This is a quick just compare and contrast of acute kidney injury and chronic kidney disease. Where do they start? Acute kidney injury is typically, at least for intrinsic, peritubular vasculature. So you're getting ischemic changes there, or you can get, this is where the cytotoxins work. In chronic kidney disease, problems start in the glomerulus. And often in acute kidney injury, glomerulus is just normal, and the problems are further downstream. Cause of damage, proteins here damaging the vasculature, and in chronic kidney disease, proteins again, but damaging the glomerulus to start with, and then downstream in the tubules. Progression of damage in acute kidney injury, typically the vasculature to start with, then the interstitium, then the tubules. Chronic kidney disease starts in the glomerulus, then it damages the tubule, and then you get fibrosis in the interstitium. Typically reversible if it's caught early enough, AKI, but not if it really progressed to severe damage. Chronic kidney disease, once you start getting fibrosis, these changes are typically not reversible in any tissue. So once people start getting fibrosis, cirrhosis in the liver, that is not reversible. Lung fibrosis, not reversible. You can try and slow the progression down, but once you start getting fibrosis, this is a sort of an irreversible change. And a summary, which I sort of did earlier on, added a few things at the end. I won't go through it now. Any questions on chronic kidney disease? Okay. Real important condition. It's becoming more prevalent, especially with the increase in diabetes. Okay. This is going to be the last class on the kidney. So whatever we get through today from this slide set will be fair game for the exam. Slides that we don't get to will not be on the exam, okay? We are not going to carry on the kidney on Monday.
Sorry, you say final?
On the final exam?
Yeah. Or did you say what exam?
The next exam is the final exam. Right. There's not, unless you want another one. Okay.
Yeah, if you drop the lowest one, yeah.
Okay. So we will start the respiratory system on Monday. We're done with the kidney today, no matter how far we get. So we're going to talk about a couple of conditions. One is nephritis, one is nephrosis. And these guys were sort of instrumental in coming up with these different terms because of the different appearances of the conditions. And then you know, as Americans, you probably pronounce this Gene Berger, but it's probably Jean Berger or Jean Berger or something like that. But, Richard Bright was English, von Muller was German, and Jean Berger was French. So, okay. And he came up with the term nephritis because what he saw was a condition where there was a lot of protein in the urine, sometimes blood, and there was an inflammatory response in the glomerulus. Okay. Well, this guy von Muller saw the same sort of thing. He saw loads of protein in the urine, but no inflammation. You know, the glomerulus, you know, yeah, maybe there was damage, but there wasn't an inflammatory response there. So it wasn't an itis. You know, itis typically refers to an inflammation. So there wasn't an inflammation, may have been some damage. So he called it nephrosis rather than nephritis. And then Jean Berger came up with his disease, Berger's disease. And we'll talk about that. These conditions are glomerular diseases where there's either an inflammatory response in the glomerulus and you know, problems because of that, or glomerular damage, no inflammation, but again, problems because of that. One of the, or some of the major factors causing these conditions are immune complexes that get deposited in the glomerulus. And there is one condition that is mediated by IgA, and it's called IgA nephropathy, aka Berger's disease, because he's the first guy to describe it. So there are acute conditions, chronic conditions, itises, and then there's something you'll come across called nephrotic syndrome. So typically, nephritis, nephritic, involves inflammation, and the nephrotic, you know, damage, but no cellular infiltrate, so no inflammatory response. Just a bit of perspective here is that if you look in the textbook for glomerulonephritis, you will see a laundry list of different conditions. You know what I mean by a laundry list? A really long list of things there. Shopping list I've got here, same sort of thing. Well, at least when my wife goes shopping anyway, it's a long list, okay? Okay. These slides, whatever we get through will be on the exam, but take a look at the others because there are conditions that you will come across. And I've sort of focused on the more common ones, the more well-known ones, rather than trying to cover everything. Some include things that we've already talked about. They're sort of, you know, relate to chronic kidney disease. Diabetic nephropathy, you know, could be considered a glomerulonephritis. In fact, it's a glomerulonephritis. So this covers some of the things we've talked about, and some of them have features of acute kidney injury as well. So this is not necessarily just a, you know, a different isolated set of conditions, but all of these conditions are sort of interrelated. And so just a reminder, I put this in because it was a new picture I found of glomerulus. I thought I rather like this. It shows everything that we've talked about. So, you know, I'm not going to go through it, but, you know, this is what we looked at before. So Bowman's capsule with the capillaries and the start of the nephrons, so where you got your podocytes. And this is the afferent and the efferent and the macula densa, so the juxtaglomerular cells as well. And this is sort of a blow up of, you know, the podocytes one side and the capillary endothelium here. And you can see, you know, these are the foot processes and, you know, the holes between the fenestrations in the endothelial cells and the gaps between the foot processes. I just thought it captured everything. Okay. General causes. Lots of different conditions, so there's lots of varying etiologies here. Different clinical features, different morphology, slightly different mechanisms. Genetic mutations. There are genetic mutations that cause problems with the podocytes and the pores. So clearly, if you get genetic problems there, then you can increase filtration just because you've got bigger pores in the first layer of cells on the tubule epithelium. Problems with the basement membrane, problems with the mesangial cells, all of these can lead to increased permeability of the glomerulus. Hypertension, atherosclerosis, some of the ones that we've talked about, these can initiate a glomerular disease as well, glomerulonephritis, such as the one we talked about for diabetic nephropathy. Another one we'll talk about today, if we have time, is immune complex deposition. And this is from autoimmune diseases and also from infections. So post-infection deposition of immune complexes can lead to glomerular disease. Various drugs can influence the glomerulus and cause problems, and then thrombi can have the same sort of effect. And we'll talk more about it's certainly the immune complex deposition, because those are fairly common. Most common immune inflammatory. There are diseases with immune complex deposition, and one is Berger's disease. Lupus is another one. Nephritis is one of the common manifestations of lupus because of the deposition of the immune complexes in the glomerulus. From several different types of infections, you can get a post-infection glomerulonephritis, and it's commonly seen with streptococcal infections. The disease has been cleared, but there are antibodies around that can cause damage to the kidney. Infective endocarditis, Hep B, HIV, and malaria. But the most common one that you'll come across is streptococcal infections. There is a drug-induced vasculitis, and as I mentioned, there's genetic mutations, podocytes, basement membrane. General features: increased glomerular filtration because of the glomerular damage. There's an inflammatory cascade, and this is in the itis, not the nephrosis, so nephritis. Inflammatory cascade causing damage to the tubules, exactly the way we've talked about it. Cell proliferation and sclerosis, decreased glomerular filtration rate, there is sodium and water retention, and this leads to increased extracellular fluid volume and hypertension, as we've talked about for some of the others. And there's increased coagulation, hypercoagulability, so the generation of thrombi. And the most common features of these conditions is large amounts of protein in the urine and hematuria as well. So you're seeing red blood cells in the urine, high levels of protein. So these are the proteinuria, hematuria are the two most common clinical observations in these conditions. You have a question, Ravi?
Yeah. The proteinuria hematuria because of the species of the glomeruli.
Right, because you're just increasing the filtration through the glomerulus. So we talked about the cutoff was a certain size and a certain charge. Well, if you open up the pores, you can get bigger molecules, so you can get proteins through.
And the negative charge.
The negative charge can disappear as well. Yeah, that's right.
Sorry, those features you had listed off, it doesn't matter what etiologies like you have on the previous slide, it's going to be these
that's right.
features.
You get the different etiologies. There's some sort of damage or structural change in the glomerulus that increases the filtration. The changes could be different, but the end result is that you're increasing filtration, and so you're getting this large amount of protein and potential for red blood cells in the urine.
Okay.
So immune deposits, depending upon the condition, these deposits can be on the blood side of the glomerulus, or they can be on the tubule side of the glomerulus. And if they are preformed circulating immunoglobulins, they will be on the endothelial side. If they are formed in situ because of an immune response in the glomerulus, they are typically they're on the podocyte side. Okay, so blood side for circulating immunoglobulins, and typically the tubule side for ones that are formed in situ. And so clearly they can have different effects on the glomerulus depending upon where they deposit. You know, the ones on the blood side will alter permeability because of increased vascular permeability. The ones on the tubule side, they will increase the permeability through the podocyte foot processes. But the end result is the same: increased filtration. Okay. And you know, again, we come back to the same things that we've talked about. There's an inflammatory response and an immune response in these conditions. And there's release of chemokines, cytokines. There's an inflammatory response with macrophages and T cells, also neutrophils. And then, this inflammatory response just gets amplified. And so you get the release of more cytokines, upregulation of NF-kappa B, so you get IL-1, IL-6, TNF-alpha, reactive oxygen species. And so this causes damage to the glomerulus and increased filtration. Okay, so nothing different there from things that we've already talked about. Okay. And then downstream, there can be damage to the tubules and the interstitium, exactly as we've talked about. One of the initial problems is this severe leakage of protein through the glomerulus into the tubules, and in chronic kidney disease, that initiates this inflammatory response in the tubules. It's the same here. So proteins trigger. This is the same inflammatory response we talked about for the chronic kidney disease. T cells, macrophages, release of cytokines, release of reactive oxygen species, release of growth factors, and upregulation of fibroblasts, generation of fibrosis and sclerosis in the tissue. So what do you see initially? So acute glomerulonephritis, clinical signs, capillary injury in the glomerulus or podocyte injury in the glomerulus, proteinuria, hematuria. And we've talked about, when we talk about acute kidney injury, we talked about some of these casts that you can see in the tubules. You can see casts as well in this condition, together with the proteinuria. Reduced GFR, salt and water retention, leading to edema, extracellular fluid volume expansion, and hypertension. Okay. Any questions? Okay. So nephropathy caused by IgA is the most common cause of glomerulonephritis, and it can lead eventually to chronic kidney disease if you get continual damage to the glomerulus. It's autoimmune, and it results from an abnormal IgA structure. And I did have the structure that was changed, so I took it out, but unfortunately I didn't take it out of this bullet here. There's a change in one of the N-acetyl galactosamine residues, so the NA-gal, and antibodies get formed to this immunoglobulin. So you get antibodies to antibodies, and they complex. So the antibodies to the abnormal IgA complexes with the abnormal IgA. and they deposit. And they deposit in and around the mesangial cells in the glomerulus. This is one of the mechanisms by which you see glomerular problems in lupus, is this deposition of these antibodies around the mesangial cells. So these IgA antibodies to IgA complexes deposited in the glomerulus. There's upregulation of the mesangial cells. There's release of the cytokines. There's release of the growth factors. There's also upregulation of angiotensin II. So again, we're coming back to what we talked about for chronic kidney disease, changes in the glomerulus. The angiotensin II is a major player. It's a problem here as well. Activation of complement. So this is all happening within the glomerulus, and so it's causing glomerular changes. What do you see in the glomerulus? Well, because of the reactive oxygen species, the mesangial cells undergo apoptosis. There's also loss of the podocytes, and because of the generation of the growth factors and fibroblasts, you get fibrosis within the glomerulus. In the tubules, the same as we've talked about. The proteins get filtered, and there's epithelial damage, and again, inflammatory cascade leading to fibrosis of the interstitium. IgA glomerulonephritis can be benign. Lots of people have it post streptococcal infections, post other infections, and it really does no damage. It can be precipitated by any mucosal infection, because often in mucosal infections you get upregulation of the output of secretory IgA. I assume you talked about that with Dr. Lindblad?
Yes.
Okay, so secretory IgA from the mucosa, that can happen, it can be upregulated when you get these mucosal infections. Respiratory infections, GI infections, but lots of respiratory infections can lead to this. And the symptoms can occur and disappear, or if it's prolonged, or if it recurs every time that you get one of these infections, then it can cause permanent damage and dysfunction. It can lead to chronic kidney disease. So it can be benign, but in some people who are more prone to this, then it can lead to permanent damage and end-stage kidney disease. How do they diagnose it? The gold standard for diagnosing glomerulonephritis is from a renal biopsy. And so they will take a biopsy. You know what a biopsy is? Yeah, okay. So they take a piece of tissue and they look at it under the microscope, and they look for certain cellular changes for the diagnosis of glomerulonephritis. The Berger's disease, where there are antibodies to the IgA, you can cause immunofluorescence with the antibodies. So that's one way of diagnosing Berger's disease. And this is what the sort of things they see when they take a renal biopsy to try and diagnose glomerulonephritis. And there's the Oxford classification for diagnosing it. What they look for is increased numbers of mesangial cells, so mesangial hypercellularity. They look for sclerosis, so this is fibrotic tissue down here. They look for increased numbers of the endocapillary cells as well, so endocapillary hypercellularity. This is the fibrosis and sclerosis down here. And this is one where they've got immunofluorescence for the anti-IgA antibodies. And so this would be diagnostic for Berger's disease. Okay. This is the last slide. So it can be rapid progression and a rapid rise in serum creatinine. It can be slow, where you get an inflammatory response and a slow increase in creatinine, more like a chronic kidney disease. And then it can sort of be between the two. So it can be anything. It can be a really rapid progression. It can be a really intermediate, and it can be a really slow progression. You see the same changes in all of these conditions, but just at a different rate. And then it can become chronic, as in chronic kidney disease. I think I'm going to leave it there. I don't feel really good about this because some of the interesting stuff comes after this, but we will start the respiratory stuff on Monday. Any questions? Okay. What we went through today, there will be 3 questions on this on the exam, so you can see that there'll be still a fair chunk on chronic kidney disease and less on the glomerulonephritis. Okay? Have a good weekend.
You as well.
See you Monday. Yeah.
If you send out, last time the exam, you said you were going to send out like an email to say to the people who got below 73. Would you mind sending an email out saying when you sent that, so we're not anxious all weekend waiting for the email or not?
We can't retake any.
We can't retake this one.
Yeah.
Never mind. Doesn't matter.
I will not send out an email well, if you've got less than 73 because there's no reason. I will just post the grade. Okay? So there's nothing to wait except posting the grade.
Are they going to be posted today?
Probably not.
Oh.
Well, I don't know. I've got to look at them and decide what. Yeah, maybe. Okay.
Now I'm anxious about that.
Okay.
Yeah, I'm going to check my.
Okay. Other question?
Sorry,
Oh no, Luke. Okay.
Curiosity, why did we decide not to have a retake on
Not enough time.
It's a long story. Okay. If you look at the numbers of people who had retaken up till this year, the numbers of people who had retaken the exams, right? It was a significant number that retook the first one, much fewer for the second one, and maybe just 1 or 2 people for the third one. And it was just decided that, the idea when we set these up initially was because some people, they came in, it was a tough adjustment for them. They really dug themselves in a hole after the first exam. And so the idea was just to, ease people into the transition. And so, not a net for every exam. Since Patho's got 3 midterms, we thought, well, the first 2 are the really important ones to help people with, and not the.
Are we going to have retake too?
No, there are no retakes in the second year. Okay, there is some type of remediation if you do badly on an exam, but it's not a retake of the exam. Second semester, I don't have anything set up yet, but I might put something in there. Okay. Because until this year, hold on, let me stop the recording here before I say something I shouldn't. Okay.